Hello, everyone. My name is Araceli Marquez, and today I will be presenting on the cancer challenges among the Hispanic population. I will begin with a brief overview and introduction, then move forward to discuss social determinants of health and cultural factors that affect cancer outcomes. I will also discuss interventions and strategies that have been used to address these issues, as well as future directions. In the US, Hispanics constitute the largest ethnic minority. Hispanics encompass 17.4% of the US population in 2014, and this percentage is projected to rise to 28.6% by 2060. Hispanic and Latinos, also known as Hispanics, have seen a significant increase in the death rate from cancer in recent years, overtaking cardiovascular disease. Hispanic men are more likely to suffer from prostate cancer with 22%, colorectal cancer with 11%, and lung cancer at 7%. Breast cancer among Hispanic women is the most common with a 29%, followed by uterine cancer and colorectal cancer at 8%. The treatment of cancer has improved significantly over the past several decades. However, Hispanics continue to experience a higher rate of advanced disease, a longer time between diagnosis and beginning of treatment, as well as a lower quality of life than other non-Hispanic whites. Although cancer does not discriminate based on an individual's socioeconomic status, lower income, lower level education, and lower rates of health insurance are clearly associated with poorer cancer outcomes. Hispanics in the US have historically had less access to health services than other ethnic groups. They also utilize fewer preventative health services prior to the Affordable Care Act's introduction in 2014. 30% of Hispanics reported not having health insurance, as compared to 11% of non-Hispanic whites. Individuals with lower levels of education have difficulty securing health insurance, as their jobs do not offer health insurance coverage or provide limited plans with substantial out-of-pocket cost. Language barriers also exist that affect employment opportunities, since about 30% of first-generation Hispanics and Latinos report not speaking fluent English and speaking primarily Spanish at home. A lack of resources presents a challenge to individuals and families who have recently migrated to the US, and they struggle to learn English and obtaining reliable employment and health insurance coverage. The combination of education and literacy challenges encountered by Hispanics and Latinos contributes to lower household income. The income disparities prevalent in Hispanic Latino communities has also been independently related with poorer health outcomes. Latinos and Hispanics are more likely to live in areas where there are not enough affordable and accessible healthy food options, so they consume high fat, high carbohydrate, and low fruit and vegetable meals and rely on fast food restaurants. Consequently, adverse health effects could occur, such as an increased risk of cardiovascular disease and a poor prognosis for cancer. Hispanics' cultures and beliefs may influence their engagement in prevention behaviors, treatment decisions, perceptions of illness, and response to cancer diagnosis and associated side effects. Hispanic cultural factors include familism, cultural perspectives in which the family's needs and objectives are placed above those of the individual, and strong emotional attachments are emphasized to the immediate and extended family. As a result of family values and female gender roles such as Marianismo, individuals are less likely to engage in positive health and behavioral changes that are not perceived to benefit the family. Hispanic women with breast cancer have indicated concerns about burdening their families with their diagnosis and have focused on their family responsibilities instead of themselves as coping mechanisms. Hispanic women with cancer have also reported experiencing machismo, with some women reporting their husbands abandoning them as a result. On the other hand, men who exhibit machismo through strong family provider instincts or protective feelings may be more likely to provide support to cancer-stricken family members. Hispanic culture is also deeply rooted in religion and spirituality, as Hispanics often consider religion to be a source of sustenance during health adversities. To recover from illness and maintain emotional, physical, and spiritual health, participants relied on God and their faith through frequent religious rituals such as prayer. It is also common among Hispanics to endorse fatalism, the belief that problems are beyond one's control and determined by fate. It is common for Hispanics to consider a cancer diagnosis to be a death sentence. A cancer diagnosis can also be very frightening because being diagnosed with cancer can become very expensive due to lack of financial resources and lack of insurance. The following factors may contribute to healthcare utilization: seeking medical attention only when ill, being uncomfortable concerning screening procedures, fear, denial, lack of motivation, not prioritizing preventative care because of other concerns, inclination for natural home remedies in opposition to Western biomedical treatment, and a lack of social support. Compared to standard care, interventions that involve mailed outreach or patient navigation seem to be correlated with the greatest absolute improvements in screening rates, with increases in screening estimated to be 22% and 18% for outreach and navigation. From 2015 to 2018, a four-arm randomized control study was undertaken at a U.S. federally qualified health center near the California-Mexico border, focusing on low-income Hispanics and Latinos. The goal of the intervention was to compare usual care, in-reach involving individual education, mail outreach offering a fecal immunochemical test, also known as FIT, and a grouping of outreach and in-reach for encouraging colorectal cancer screening. To classify the study sample, they searched the FQHC's electronic medical records for people aged 50 to 75 years old who were not up to date on CRC screening, self-identified as Latino, and a minimum of one primary care visit in the previous year at a single primary care clinic. The study findings showed that material sent by mail, such as a primer and offered to fulfill screening and a live telephone reminder, was superior to individual education with a live telephone reminder among Latinos. Therefore, the study results back up previous findings and extended current research that sending communication through the mail is superior to usual care, and in reach, including patient education, is superior to usual care among Latinos. In light of these results, leaders in cancer control, public health, and healthcare organizations such as FQHCs should consider mailed outreach as a first-line option for screening promotion in resource-constrained settings rather than one-on-one education. A study tested the impact of a promotora workplace-based intervention on Latino employees in service and manual labor jobs in Utah to increase breast, cervical, and colorectal cancer screening awareness and adherence. During the study, they collaborated with promotoras from two community-based organizations and local businesses to deliver patient navigation for affordable cancer screening services and cancer prevention education. Pre-surveys and post-surveys were used to evaluate the effectiveness of the intervention and to assess changes in the participants' knowledge about recommended cancer screening ages and frequency for breast, cervical, and colon cancer. Considering that only 26.8% of the sample had health insurance, this intervention improved knowledge and adherence about cervical, breast, and colorectal cancer screening guidelines among Latinos who may not be receiving information about cancer screenings from providers. Promotoras are trusted members of the community who typically reflect the cultural and linguistic background of participants, and they represent a trusted source of information for Latinos. Future educational interventions that are culturally tailored to promote colorectal cancer screening and ultimately lower colorectal cancer screening prevalence rates would be a great way to improve screening rates and lower the rates. This educational intervention focusing on facilitators and barriers to screening could be carried out by educators or community workers, include group discussions within the community, and it could be implemented in community settings. These strategies could also be used with other common cancers among the Hispanic and Latino population to improve screening rates and reduce prevalence rates. For Hispanics to access and use health services effectively, cultural sensitivity and health literacy need to be enhanced, particularly as they relate to controlling chronic diseases, promoting healthy lifestyles, preventing obesity, and improving workplace safety. Studies have shown that Spanish-speaking health providers have improved patients' health-related adherence and satisfaction, as well as control of chronic diseases. Hospitals who have a large Latino population should start a health literacy task force and have plans and strategies as to how staff can implement this to better assist their patients. In terms of clinical care, cultural mistrust and language hurdles between patients and physicians can obstruct treatment decisions and ultimately care delivery. The oncology workforce must be diverse to provide culturally competent care and education. Patient navigators help patients understand their diagnosis and make informed treatment decisions by providing evidence-based, unbiased information, thus increases their access to medical services to seek timely cancer treatment. They can assist in connecting them to programs and services that provide hope, support, and assistance as they navigate their cancer experience. Additionally, the COVID-19 pandemic has disproportionately affected Hispanics in comparison to non-Hispanic whites, and its impact on cancer screening incidence and mortality among Hispanic population in the United States deserves careful monitoring. A culturally appropriate lay health advisor, as well as patient navigators and targeted community-based interventions to facilitate access to healthcare and promote healthy behaviors, are evidence-based strategies for reducing cancer mortality among Hispanics. To inform the community about the resources available to them, community outreach is essential. In the Latino community, many people work long hours and don't prioritize their health by taking time off from work. Mobile clinics could provide free or low-cost screenings and preventative services on site. Medical expansion to cover low-income individuals regardless of age and documentation status would be another significant step toward cancer treatment. Additionally, hospitals could raise funds and possibly partner with other organizations to help cover the cost of cancer treatment for those patients who cannot afford it. Community resource centers can also provide health education classes on self-examination and provide infographics to the community. Additionally, it is crucial to address the social determinants of health to improve the overall health and well-being of Hispanics and Latinos. Thank you. That concludes my presentation.